Juha, are you there?
Good afternoon. Afternoon.
Hey, Juha.
Hello, John. Hello, John.
How you doing there?
I'm okay.
Good. Very good. So we have the king today.
Yeah, King. We are waiting for him. I hope Subin can join. We had some difficulties.
Oh, really?
Yeah, but Jihan is telling that because it is US address, it's more difficult to come inside, no?
Not as easy as before.
Oh,
Not
so,
as easy as before. Some restrictions have happened.
oh, okay. Okay, well, we can go ahead. I hope we don't have to, but we can go ahead, right? Without Ben?
Now, let's see. We have
Okay.
10 minutes. 12 minutes.
Yeah. Well, yeah. We can wait. We can wait longer.
Of course. And the king is not here.
Okay, yeah. He comes at the last minute. Yeah, the Chris Lawton series is going well. We just did the fourth one last night, and they have two more. It's two more. They're also Dr. Lee. I guess he's a fellow in Arkansas from China.
Yeah, Shai Lee.
Oh, you know him?
Lee Shai. Yeah, I know him well. Yeah.
Oh,
He's a
okay.
good guy, yeah.
Oh, he's from your area?
No, I met him in Little Rock Arkansas several
Oh,
times.
okay.
We have been
Yeah.
in connect, speed chatting, and so
Yeah, he's been there
he's a very
three,
nice guy.
3 years, right? He's been there.
3 years
Three.
now. Yeah.
Yeah, I guess he likes to do the translation.
Yeah, he 3 years ago he was not speaking so well English, but has learned very well now.
Really?
Of course, he wants to stay long time in USA and then come back maybe.
Do you take fellows at your hospital, or no? It's kind of frozen now.
China is closed, so
Yeah,
you
it's
cannot
closed, yeah.
take.
Yeah, can't do
Cannot
anything, huh?
I have many people who are asking, but I have to tell
Right.
them that China is closed.
Right,
Or
right.
you
Well,
don't
most
get the
countries
visa.
are. Most countries are for fellowships, right? Probably.
Yeah, you don't get the visa, and then if you get the visa, then you have 3 weeks quarantine, and so it is big suffering, and so you cannot visit. Or if you come for a longer time, then it's okay, but you don't get the visa for fellowship.
Does anybody want to say hello to Juha? Now's that we got some time. We got a few minutes.
I
We're
see
just kind of-
Nasruddin is here. Where are you coming from, Nasruddin?
Hi, sir.
Hello, nice to meet you.
Hello, nice to meet you. I am from Iraq. I am neurosurgery resident last year of my training.
Okay, which city you are?
Slemani, north of Iraq.
Mm-hmm.
the Kurd section.
This is, I
Yeah,
know,
yeah,
only
yeah.
Mosul.
Kurdistan
I
region.
have visitors. Is that close to
Kurdistan
Mosul?
region. Actually, not so much.
Mm-hmm.
Close to Erbil, if you have heard of.
I don't know.
Erbil.
I have never been in Iraq. I had some visitors from Iraq, and they were from Mosul. So
Yeah,
yes.
there was a fellow from Slemani called Dr. Amanch.
Oh, okay.
Stayed with Professor Juha for 6 months, I think.
Mm-hmm.
In Finland,
Okay.
I think.
Yeah, in Helsinki. Yeah.
I heard from Ben. I'm getting a hold of Ben now. Okay.
Is there some special address you have? Can you help him join?
Hello, Professor Juha. How are you?
Hello, Abdi. Hello, Abdi. Nice to meet you.
Nice to meet you.
Okay, he'll be in a second. Yeah, we got 7 minutes anyway, so he'll be here.
Abdi, you have a good cadaver laboratory in Mumbai, in your hospital, or how is it?
Yes, we have a good laboratory.
So
Very
how many places for you have? 10 places. Yeah.
So we have one in anatomy, and we have a small microneurosurgery lab in the department itself, with microscope and prism for just for brain dissection and stuff.
Is it easy to get cadavers in India?
Yes, it's not that difficult. It's not that difficult.
Oh, Dr. Takashi's here. Abby, you're following me. Abby just had a conference for the women's WFNS.
Yeah, I noted. I didn't follow, but
Abby gets around.
Today was really close.
Is that Atul around? Do you know?
He should be joining soon.
Okay. Here's Ben now. Same problem as last week. I just sent him the wrong link. Facebook is hooked up with products you don't know about. And if you use a Facebook product, you can't use it in China. And I was using like a link shortener. Do you know what that is, Abby? A link shortener that makes a link short. It's like a program, but it must be a Facebook product. Hello, Ben.
Hello, Sue.
Hello, John.
Hello.
Hello, Professor Ernest Nemi.
Hello.
Hello, Rita.
Hello, Dr. Bin. How are you?
Sorry about that, Ben. The same mistake. Same as I said.
Yeah.
That I use a link shortening.
We can't log on through the Facebook.
Yeah.
John?
Yes.
John, can you send a link to Dr. Goel? I think he's not able to connect. Can you send a direct link?
It's probably the same problem. Okay. What should I send it to you, Abby, or what?
No, send it to him on his email.
Okay.
So he can
Yeah. Okay. There, you got it. I'll send it to his email too. Yeah, we got 4 minutes. Oh, here's a tool. Abby, the trumpet players have the night off. We can't raise the trumpets for his arrival. And Carlo.
Okay, John.
Hey, Dr. Goa, how are you?
Hi. Good evening. Juha, how are you?
Good evening.
Hi.
Fine.
I can see Ben.
Hi, Professor.
How are you,
Goh.
Ben?
Fine, thank you.
You know, my internet connection was a little bit weak. I don't know why.
先防弹后防迷散吗？
啥？
蛋炒饭是先防蛋后
Okay,
防迷散
okay.
吗？
I'm sorry. I need to
Carlo,
mute.
Sarah.
I need to mute somebody.
电车就打单。
Good evening, everyone.
Hello, Takashi. How are you today?
Yeah, I'm fine. I just arrived from my work. And,
Okay.
It's 9 p.m., so it's okay.
Thank you for coming.
Thank you.
Yeah, I'll introduce the translators before, okay? And then to you. We got 1 minute.
So I will give a short introduction and then.
Yeah. Okay. You want me to just? I want to introduce the translators, or do you want to wait till after? Yeah, that's all I want to do is introduce them, because they're doing a great job. They're doing a great service for us. Okay, ready to start a tool. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. It's Dr. John Bennett for Neurosurgical TV. We have the honor of having another Juha's China Neurosurgery Grand Rounds, and we have the king of the Zoom. I call him a king because he does so many. He's dedicated to teaching. But let me turn it over to Juha. Okay, Juha, you can introduce Atul.
Yeah, they're all dear friends. Today we have again Professor Atul Goel to speak on gliomas this time. So I repeat my introduction. So Professor Atul Goel from Mumbai is one of the most important neurosurgeons of these times in the world. How to become a good neurosurgeon? Train hard, follow the way Professor Atul Goel is doing. Neurosurgery has 3 parts: operative skills, then research, clinical and basic with publishing, and then teaching. Like mentioned, Atul is the king of webinars. He has extremely passionate and very convincing lecturing, and this is a very good way. You should learn that. There was a discussion in Facebook that some people are great in surgery but cannot give lectures. I think this can be also trained, and Atul is one of the good heroes to follow. How to improve all the time? You should analyze your experience, and this makes you 5 times or even 10 times better surgeon. Publishing is very important. There's a lot of speaking about paper tigers. This is nonsense. If you publish and analyze your experience, then you certainly develop better surgeon. You should not believe everything that has been done. You should think again and not rely on all old methods. You have to try to find something new if it is better. Thinking and observing the patient care is extremely important, and you should be open to learn from others and correct your old ways if you see something better. So here is a selection of the most important neurosurgeons in the world neurosurgery, and the 69 important neurosurgeons in the world: Cushing, Dandy, Yasakil, Spetzler, and here's Atul Goel, certainly one of the most important. And he has published extensively, more than 800 publications. And like we heard last time, it has been very difficult to publish because his publications are very special. So last time he told that it was nearly impossible to publish, but he could break the curtains, and he has now spread his knowledge and experience around the world. He's doing extensively operations, 1,500 personal operations a year. How can you do it? You have to be excellent in a surgeon, of course, but you have to organize well your clinics, and you have to have a good supporting team and the patients and society around. And of course, you have to have a big flow of patients. This means big country. You should train your best young people. They should become better than you. We know Abdi very well. She has been extensively involved in publications of Atul and certainly doing great job and has great future. So we let the king of webinars fly freely. We will hear certainly a very passionate and good lecture on gliomas. Atul, please go ahead.
Thank you, Juha, for the very nice and very fantastic words. And it is indeed my honor to speak in Juha's grand round. I know he has selected very senior and very illustrious neurosurgeons, and to find my name in that list, I am extremely honored and proud. And to see Bin Zhu translating into Chinese is another big honor. Bin Zhu is absolutely amazing surgeon and an amazing friend and amazing person. And I'm very, very proud that he's on the show. And of course, Dr. Takeshi from Japan, who is also here. And so to see all these people and to talk in front of them is indeed an absolute great privilege and honor. So I'm going to talk on a very common subject of neurosurgery, a subject with which every neurosurgeon has to deal with in his career: glioma surgery. Gliomas and meningiomas are very common neurosurgical material, and we deal with this surgery throughout our life. So I am trying today to introduce a new concept and a strategy based on this concept about glioma surgery. Just try to see if it suits your imagination. We all do glioma surgery. We all know how to do glioma surgery. We have learned neurosurgery. We have learned how to do hemostasis, how to remove this tumor, how to radically remove this tumor, which tumor is in good location, which tumor is in bad location, which tumor is vascular, how to achieve total tumor resection, how to dissect the tumor completely, which tumor is aggressive. Necrotic changes are suggestive of aggressive tumor. Extensive edema is suggestive of an aggressive tumor. Neurological deficits are suggestive of an aggressive and kind of glioma. So we know gliomas. Everybody knows. So I am in the field of glioma surgery for all my career, all my life. Essentially, in an academic department like mine, high-grade gliomas like this were considered to be a resident training material. Like you train the residents how to remove the tumor, how to do hemostasis, how to achieve radical resection, the techniques of breaking the tumor, techniques of dissecting the tumor. These are essentially, and these were essentially, a resident training program. So the senior person will like to do skull base and all those kinds of petroclival and cavernous sinus surgery. And a young resident will learn his neurosurgical skills on gliomas, on meningiomas. So this is a general trend. This was at least a general trend, at least in my own department. But for the last several years, I have been involved in gliomas more seriously than I was involved earlier. So gliomas, what are gliomas? And how to handle and treat gliomas is the subject of today's discussion. Low-grade gliomas. In my own understanding, low-grade gliomas were considered to be diffuse. Means they were diffuse. Invasive. When you talk of low-grade gliomas, means invasion into the brain. Infiltration into the brain. Many of these low-grade gliomas are located in very critical areas like motor strip, premotor area, in the speech area, in the insular area, in the visual cortex. So they are located in critical areas, they are diffuse, they are infiltrative, and the presenting features are relatively subtle. Means the symptoms are like convulsions, some headache, some higher function disturbances in a moderate fashion. And to remove these tumors was a danger. You remove motor strip tumor and you create hemiplegia. You don't want to do hemiplegia. You don't want to remove this tumor for biopsy, histology, because biopsy is not relevant. You see, you can make a diagnosis on imaging. This is a low-grade glioma. Any radiologist, any MRI specialist will tell you. So to take a histology biopsy is not necessary. The other thing is, even if you take a biopsy, the radiation people may not give radiation because it is so low grade. So the histology is obvious, the location is dangerous. So these tumors, there was a wait and watch policy. So what the general trend for low grade gliomas is wait and watch, don't do anything. These are low grade tumors, they will not grow. Of course, this concept was not correct. This concept was wrong and erroneous. And there have been many famous people in the field of gliomas, like Defoe. He's a very well-known figure in the field of low-grade gliomas. We have Mitch Berger from San Francisco, very famous name in low-grade gliomas. So these people have said that low-grade gliomas can be removed radically. They can be removed aggressively. They can be removed totally. Totally. This word you must remember, totally. And they can be removed safely. So these are, there are some, I have named only few, but there are many other people in the world of low-grade gliomas. The other concept that Mitch Berger and Defoe keep on talking is, you remove the low-grade gliomas totally or radically, you improve the quality of life. And you improve the longevity of life. So these concepts have now become quite ingrained, and now majority of people in the world believe that low-grade gliomas can be removed radically and effectively. Glioblastomas also can be removed radically. There are people talking of supra resection, supra-total resection, aggressive resection. And the concept is, you remove radically, you improve the quality of life. So these are the thoughts. And more recently, to remove a low-grade tumor radically, there are various equipment like neuromonitoring, which shows where is the motor strip. You avoid that motor strip. There are cortical stimulation, subcortical stimulation, speech area evaluation, awake craniotomy, and things like that, which make low-grade glioma surgery safer. And there are extensive intraoperative measures to evaluate, like intraoperative CT scan, intraoperative MRI, navigation tools, ultrasound to evaluate if we have removed it completely or not. If not, come back and remove completely. So these are established protocols for glioma surgery. And there are intraoperative fluorescence guided studies. We all know about ALA and various other dyes, which give you information during operation that there is some tumor remaining and that tumor has to be resected. So these are the mapping, brain monitoring, functional mapping. There are various kinds of tools, and this has become a discrete branch of neurosurgery. This, how to remove a low-grade glioma or a glioma of any grade radically, this has become a very discrete branch and very elaborate branch of neurosurgery. Yasser Gill, you see, Yasser Gill was one, I will call him a hero of low-grade glioma surgery. He was one, and of course you heard Ugur Ture in the last Friday juha grand round, how he talked about. So juha has invited one of the more famous people in low-grade gliomas like Yasser Gill and Ugur also. There is no question about that. So there are only very few articles in the literature that mention how the gliomas grow. How the gliomas grow from one gyrus to the other along the fiber tracts. And This was Yasargil's article, which said that gliomas go from one gyrus to the other gyrus, and then it essentially goes along the vascular supply, like middle cerebral artery. If you get an infarct, there is a wedge-shaped infarct. Similarly, gliomas go towards the ventricle, and this is the article written by Yasargil. So he said that they go along the fiber tract. So I want to introduce a new concept. I want to introduce a new feeling about glioma, and that concept is that gliomas are confined. Now you see this my recent article on gliomas. Gliomas are confined to a named fiber white matter tract. They are confined to a named white fiber tracts. And this, if you understand, there can be a revolution. There can be a complete revolution in the understanding of gliomas and in the surgery of gliomas. The concept is gliomas arise from a white fiber tract, from a named white fiber tract, and displace the adjoining tract. The adjoining tracts are involved by virtue of deformation and pressure, not by destruction. So there is a well-defined plane of dissection between a normal white fiber tract and a tumor-involved white fiber tract. So they are confined tumors. And on the basis of this concept, we introduced a strategy of en masse tumor resection. So the title of my article is en masse tumor resection a safe surgical strategy for low-grade gliomas? This is my subject which I am going to deal with you today. We know the anatomy of the brain, we know the anatomy of the blood vessels, about the arteries and how to deal with the aneurysms and all, and how to do stereonal approach. This also was one of the very big contributions from Yasargil. And then, of course, we know how various people, including Juha, have developed great mastery on vascular surgery, on opening the sylvian fissure, on dissecting in the subarachnoid spaces, and reaching the aneurysms and reaching the aviums. We know all that. You remove the blood vessels, we know about the frontal brain, about the temporal brain, about the sylvian fissure, about the occipital brain, about the parietal brain, about the sulci and gyra. But what has really changed the surgery of gliomas is the understanding of white fibers. White fibers, you see, these are the short arcuate fibers shown in all its glory and beauty. These white fibers of the brain were not really understood about, I will say, 30 years ago or 35 years ago. We never talked about white fiber tracts. And of course, Yasargil and Klinger and all those people, and many people before also have talked about it, but they have never been exploited in glioma surgery. And they have not been understood. And in our neurosurgery program, the residents were not told which white fiber tract is close to the tumor. This is a glioma. Tell me, which white fiber is close to the tumor? We were not asking this question. And white fiber have various kinds of functions, like superior longitudinal fibers, SLF, SLF1, SLF2, SLF3. SLF1 is medial, SLF2 and 3 are lateral to the projection fibers, which I will discuss, have a role, have a function. In the non-dominant, they get neglect syndrome, visual-spatial attention, difficulty or initiation of motor activity, arcuate fasciculus, we all know, and I will talk about it. Cingulum, how is cingulum involved in the limbic system, in the behavior and emotional IFOF is one of the biggest and the strongest fiber tracts. We were not taught about these fibers, but they are very important fibers and responsible for semantic paraphasia. Uncinate fibers are also involved in limbic system and behavioral and emotional optic radiations. Of course, we know middle longitudinal fibers, fasciculus, inferior longitudinal fasciculus, corpus callosum, anterior commissure. You see, anterior commissure, the anatomy of anterior commissure was not at all clear. We know that the anterior commissure, from the anterior commissure goes along the sylvian fissure along the insula and goes right in the frontal and the temporal and the parietal brain. The fibers, hippocampal commissure, internal capsule, and all those things are such important and crucial white fibers which were not very clearly understood. So we wrote one article with my colleagues, and of course my daughter also is here, neural circuitry and fiber dissection, and we have got several articles in my, and you know Dr. Shah, who is sitting here, who has done, and my other fantastic colleagues, Dr. Sukhdeep Jhawar, who is one of the finest dissectors in fiber tracts in the world, I will say, and I will show you some of the work. So we divided fiber tracts into horizontal group and a vertical group. Vertical group is this projection fibers. These are projection fibers, the vertical group. The horizontal group these are the superficial group of the short arcuate or short association fibers. These are the superficial group. Middle group, this is the middle group, which is the SLF, arcuate fasciculus, middle longitudinal fasciculus, uncinate fasciculus, IFOF. So this is short fibers. This is the middle group. This is the deep group of fibers where we involve the fornix, stria terminalis, stria medullaris thalmi, and lateral and medial longitudinal fasciculus, and the central group of the corpus callosum and anterior commissure and posterior commissure and habenular commissure and hippocampal commissure. So essentially, all neurosurgical trainees and neurosurgeons have to know these white fibers if they have to do glioma surgery elegantly and beautifully and perfectly. So these white fibers, nobody can say now in the modern neurosurgery that no, I don't want to know these fibers. I don't want to learn these fibers. It is impossible, means nobody should do that. Then we divided gliomas into two groups. We said that gliomas arise from a named white fiber tract, and it goes along a white fiber tract. So these are short arcuate fibers. We call it localized or focal gliomas when they involve a short arcuate fiber and they are located in that vicinity. They go from one gyrus to the other gyrus but they are localized. We call these gliomas, like this is the cingulum glioma arising from the cingulum and goes along the fibers of the cingulum into the parietal lobe, and this connection of the cingulum white fibers to the parietal lobe are very crucial and important fiber tracts. And when you do transcallosal surgery, you have to understand this cingulum and its white fibers. So these tumors which go in the, one is short arcuate gliomas which are local or focal. One is deep, like corpus callosal glioma arising from cingulum and arising from the deep group of white fibers are diffuse. So we divided into two groups, these gliomas. This is glioma arising from corpus callosum. It goes along the corpus callosum, and it involves the fibers of the corpus callosum and goes from one lobe to the other lobe. So we wrote this article about how the anatomical extension of gliomas is based on wide fiber tracts. And we have proposed this novel classification. So just to summarize the various fiber tracts for you, you see this is the beautiful IFOF, this is the arcuate, these are SLF fibers, this is the uncinate fibers, this is MLF, and there are various other, these are blue thing is a projection fibers. You see these projection fibers, they go vertical fibers or projection fibers, and they divide the horizontal fibers into medial and lateral. So let me show you. This is the projection fibers. So they divide the horizontal fibers into two groups, medial to the projection and lateral to the projection fiber. So I will tell you one thing. If the tumor arises from the lateral to the projection fibers, they will displace the projection fibers medially or anteriorly, but they will not transgress the projection fibers. Did you get my point? What I'm saying is, projection fibers will be displaced. They will be deformed, but they will not be destroyed. They will be affected in function by pressure and deformation, not by destruction. The tumor arising from the short arcuate fibers will be localized. It will grow bigger and bigger and bigger, but it will be in the defined space of short arcuate fibers, and it will displace the projection fibers and other fibers in the vicinity. I will elaborate this point very beautifully. Just relax. So this is the tumor. This is the posterior frontal glioma, as we know. It is displacing the SLF downwards. It is displacing the projection fibers posteriorly. It is a localized tumor. So it is not a diffuse tumor. It does not go into the SLF, does not go into the projection fibers. It is a localized tumor. It is a confined tumor. It has a well-defined plane of dissection. And you see, you do fiber dissection studies and you can know exactly. So what I do nowadays in my department is, my resident has to know, if this is the glioma, which are the fibers in the vicinity and which are the fibers we have to dissect and protect. There is no way you can avoid, and then we do higher function examination and assessment to assess what are the functions related to this tumor. This is another tumor you see. This is in the post-central gyrus. It is, you see, it is displacing the projection fibers laterally. You see, these are the projection fibers displaced laterally. The fibers are displaced, they are not destroyed. Let me show you other one. This one is in the region of another tumor in the region of post-central gyrus. It is displacing the projection fibers anteriorly. So if you have the concept that this tumor is displacing the projection fibers, then you can remove this tumor. If you think it is involving the projection fibers, then it is not possible to, you will be worried that whether I will damage the tumor. This is another tumor in the angular gyrus. See, angular gyrus on the left side is related to a huge number of fiber tracts in the vicinity. You see, we have to know all this, like arcuate fasciculus is in the vicinity, IFOF is in the vicinity, SLF fibers, MLF fibers, projection fibers, all these fibers are in the vicinity. They are related to speech function. They are related to not only connection of motor with the sensory, means arcuate fibers and so many other fibers in the region of angular gyrus are very critical, and we have to know and learn. So when we are doing this tumor, we have to know where are the fibers. The bottom line of what I'm trying to say is, these fibers are all displaced and not invaded by the tumor. Now I will show you some cases. Now you just tighten your seat belt and see what I'm going to. This is the region of supplementary motor area, close to the precentral gyrus, as we know. And this is a dangerous area for surgery. Agreed? This is a dangerous area for surgery. Projection fibers, I am saying, are displaced by the tumor. Now you see these tumors are done with the help of many people do awake craniotomy, neuromonitoring. Now you see this surgery. I am doing this surgery. Initially, I was using neuromonitoring for all these patients. Now I don't use neuromonitoring for many of these patients. Initially, I was using awake craniotomy for many of these patients. Now you see this style of dissection. See, this is in the supplementary motor area. And I am dissecting the tumor en masse. I am identifying a plane around the tumor, and this is identifiable. And I will show you how you can remove the tumor like a meningioma. And you must know that this tape which I am showing you is is a very little editing, not much editing. This is complete live surgery. And I am not editing this tape. And you see how I am getting a plane of dissection around the tumor. And I am removing this tumor en masse. Neuromonitoring is, of course, helping me in this case, but more recently, I don't even need neuromonitoring. The whole tumor can be removed without a single coagulation. This is another beautiful thing. You see, this is not editing tape. Only some editing will be done, which you will see yourself. And many of these, low-grade gliomas, if you do monitoring, awake, and all those things, many people do these operations in 10 hours and 15 hours. And you see, of course, time is not the criteria. What I'm trying to say is that these tumors can be removed en masse if you know, and they can be held in hand, and you can get a well-defined dissection plane, and you can remove the tumor from the adjoining brain in a well-defined manner. So you see this dissection. This is a different kind of dissection, which you see, and also if you realize here, there is a lip of tumor which is being dissected from a premotor area. Now you have to remember that I am dissecting this tumor from the motor cortex. And you must know that these are very critical brain, and you can use subcortical mapping, you can do cortical mapping, and you can do continuous monitoring and bipolar monitoring. You can do, of course, and you have to do, because in the motor area, you don't want to create a hemiplegia. But what I'm showing you is a complete live dissection. In exactly 5 minutes, you have seen that the whole tumor, the complete tumor has been removed without a single coagulation and in an en masse fashion. And you can, if you have good enough experience, you can develop a plane of dissection. You see how I'm developing a plane of dissection from normal and abnormal. And if you realize that I have not coagulated even once in this operation, and of course you have to know which fibers, where are the more critical areas of the brain which you have to avoid, and you don't have to damage, and you have to continuously imagine how you have to safely remove this tumor. You cannot say I have removed this tumor in an en masse fashion and I have created hemiplegia. You see, complications can be possible. Complications are possible in neurosurgery all the time. But I am trying to tell you that a radical, total, and complete resection of the tumor is possible in an en masse fashion. And this is a complete resection of the tumor. And if you have a defined plane of dissection, you can remove the whole tumor in a complete, and these are neuromonitoring map which is shown here, and this is a supra-total resection of the tumor. Now I will show you another tumor. You see, this is in the pre-central sulcus. You have to know this is the central sulcus and the motor area, very critical. You cannot damage this person. You cannot damage these projection fibers. You have to know exactly where the brain, where the fibers are displaced. And I am telling you, there is a well-defined plane of dissection between the normal brain and the tumor. And I will show you this. Another, you see, I use intraoperative navigation, of course, to identify the site of the tumor. I use intraoperative ultrasound to identify the site of the tumor. But more important than these technological tools, you have to, from the color of the tumor, you see, this is the normal brain. This is the abnormal brain. You have to identify normal brain from abnormal brain. And then you see how I do this dissection and make a plane of dissection, and the entire tumor can be removed without a single coagulation and safely from most critical areas of the brain. Only thing is, you have to learn this dissection technique. This is not like you don't remove meningiomas like this. But you see, learn the way these tumors extend and learn the art of dissecting normal brain from the tumor. You see, I am holding the tumor like a meningioma, like a convexity meningioma, and I am making a plane of dissection. You see, this is the motor strip, and you have to do intermittently. If you are having some confusion, you can do bipolar monitoring, subcortical monitoring, and all those things are possible. How to do dissection in a little bit of a bleeding situation in one go, and then identify the normal from abnormal and make a plane of dissection and remove these tumors en masse. And I am telling you, this kind of dissection, if you can do it, is a radical tumor you can remove, and you can remove the tumor safely and completely. And whenever you want to have, whenever you are working in a critical area, motor strip and all those things, you have to certainly, of course, use the monitoring gadgets and all those things. But more important is to visually identify these tumors are gritty, tumors are firm than normal brain. You can identify, you can hold the brain, you can hold the tumor and identify the brain, and you can remove. And you must know that what I am showing you is an unedited version, almost an unedited version of the operation. And you see the motor strip is completely here and intact. And you see this is the tumor completely removed, and this is the patient, and this is the complete removal, and I will say supratotal resection of the tumor. So this en masse tumor resection is a strategy, is a concept. You have to know that these tumors have a well-defined plane of dissection. These tumors involve a fiber tract, named fiber tract, and displace the adjoining tract. Now, this is another tumor. You can imagine this tumor, and you do functional mapping, the motor strip mapping, how the tumor is displacing the projection fibers, SLF, MLF, IFOF, all those things you have to, of course, understand. This is a huge tumor, as you have seen, quite a large tumor, and I'm showing you more difficult areas. Imagine these tumors, if I show you in the frontal area, in the less difficult area, it is much simpler. But what I'm trying to show you is in the more difficult areas also, this kind of dissection is possible. Now you see this dissection. From the surface, you can know that this is the abnormal tumor. You can use ultrasound to identify. You can use navigation. Of course, I use navigation to identify where is the tumor, and accordingly we do the dissection. Now you see I have identified, and you just see this dissection. Little bit editing has been done, but not much. And you see how I am developing a plane of dissection between the tumor and the normal brain. And when you are coming to more critical areas, at that time you can do your dissection, in a little bit more protected manner. When you are doing in the region of SLF and MLF, maybe a little bit aggressive you can become. But the region of projection fibers, when you are doing in the region of speech area, when you are doing, you see the whole tumor. Now what we have done is, my wife is a neuropathologist, and I have identified the whole of this tumor. You see the entire, this whole of the mass which I am removing is, the whole thing is tumor. There is no normal brain in the substance of this tumor. And you see how I am removing this tumor en masse with the concept that these tumors are like, when you are doing pituitary tumors, for instance, you are doing subcapsular resection. You have to remove the pituitary tumor for Cushing disease if you have to. So this is not like subcapsular. It is, it is also, the tumor. I'm not saying you remove the tumor and the person is cured, but this is the way I feel that you can remove this tumor radically. You see how I'm removing the tumor? The whole gyrus, the entire thing is tumor. And I am developing a plane of dissection between the tumor and the normal brain. So my concept now is that these tumors are confined tumors. These tumors can be removed radically by developing a plane from normal and abnormal, and the whole thing, the whole gyrus is completely tumor involved and can be removed. And this is a method of removing the tumor en masse radically, completely. And this is, I call it a supra-total kind of resection. And if you have realized that I have done this dissection in exactly 5 minutes or less than 5 minutes, this is not an edited tape. This is a complete resection. And many a times I don't even use any kind of monitoring, no awake craniotomy. I have reduced my awake craniotomies quite significantly. And you see the whole tumor has been radically and completely removed. The question is whether you can identify normal from abnormal, whether you will be able to define that plane. Sorry, this is the same thing. And you see the whole tumor has been removed beautifully and completely. I know not many people in the audience may be too much interested in low-grade glioma surgery, but this is a very important part of our neurosurgical life. And you can remove the whole tumor in one shot, in 5 minutes. And you can avoid all these kind of complex monitoring and awake, this thing you do awake and he coughs and he shouts and he pain and you ask him, is this table, is this chair, is this horse, is this donkey, and all those questions, and he thinks what you are asking me. You can avoid all those things. The question is whether you can do it, whether you agree to this kind of surgery. Now I will show you another one. You see, this is in the posterior frontal area. This is a defined tumor. And if you realize, you see, this is the tumor and this is the normal brain. You see, you can make a difference. Little bit my craniotomy is off center, but you can clearly make out that this is the tumor. Now you see this dissection, how I do this dissection. This is the normal brain, this is the tumor. And this is relatively safer area of the brain. Like I was showing you earlier, more complex areas of the brain, like motor area and pre-motor area and those kind of areas. But this is a little bit safer area. You see how I am developing a plane of dissection. Now you please don't worry too much about the bleeding, because these are not edited tapes. These are complete operations. And you see how I'm developing a plane of dissection. I'm holding the tumor in one hand and I am making a plane of dissection And if you are able to do this, you can avoid using ALA dye and intraoperative fluorescence and getting confused by that. You see how I've developed a plane of dissection? And this is completely and beautifully, you see, don't worry about this bleeding. I will beg you not to think about blood, because this is not an edited tape. You must remember that I am removing this tumor en masse in exactly 3 minutes of surgery in a plane of dissection, because I believe that these tumors are defined and confined tumors, and they can have a well-defined plane of dissection from the adjoining brain. You see this? This is an art of dissection which has to be learned and which has to be developed. This is not like subarachnoid dissection, which is bloodless. You see, this is, you're working in the brain matter and it will bleed. And glioma surgery, you have to know. But you can also see that I am doing the whole tumor resection without a single coagulation. Without a single coagulation, this is like I am removing a convexity meningioma from the brain, from in a subarachnoid plane. Of course, this plane is not subarachnoid. This is a brain parenchyma. You have to develop a plane of dissection. And that plane of dissection is not like brain, like a meningioma. You have a subarachnoid and there is CSF coming and clear brain underneath. It is not like that. This plane of dissection from normal and abnormal will have to go through the cortex. And you have to know where is this normal cortex and where is this abnormal cortex, and you have to remove this tumor. You see, and such a large mass, you can imagine you remove such a large mass, there is a possibility that you avoid completely the radiation treatment. There is a possibility that you completely avoid, you can actually, I will say, many people are now talking about that these tumors can be cured. And if you do this kind of radical resection of these tumors, there is a possibility of cure from a glioma. I have little bit edited here, but that is, of course, so this is the tumor which has been removed, and this is the tumor, and completely, and I have got a follow-up of 8 or 9 years of this patient, completely no recurrence of this tumor. So this is another tumor. You can imagine the location in the region of the motor strip, in the region of the premotor area, in the region of supplementary motor area, and this is the tumor which has been completely removed. This is another tumor in the motor area. You can see this, and this is the tumor removed en masse and in a beautiful fashion. I'm not saying that, you know, I have got some patient who develop SMA syndrome postoperatively, but permanent hemiparesis or permanent hemiplegia is absolutely rare. Now, this is another tumor. You see, this is a relatively better area in the region of angular gyrus, in the region of various fascicles, white fiber tracts, arcuate fascicle, IFOF, optic radiation, SLF, MLF, all these fibers are in the vicinity. You can remove this tumor beautifully and completely, you see, in an en masse fashion, in a supratotal, and you can cure. This is a young man, and I have got several years of follow-up in this person with no tumor recurrence, and completely he had come with higher function disturbances. He was not having severe giddiness, several convulsions, not a single convulsion. So there is a potential of cure of this person. You see, now this is the tumor, normal and abnormal. You have to identify which one is the normal brain and which one is abnormal brain. This is the art. And you can use the neuronavigation, you can use ultrasound, and you can use an identification of normal from abnormal. And that is the trick of removing, and then remove the tumor en masse. This, of course, is a very, I showed you operation in more dangerous area. This is not a very dangerous area. Of course, every area is a dangerous area, but these are much safer to remove, and you can remove these tumors in good 5 minutes or 10 minutes. Another thing which I want to point out is See, I'm talking of low-grade gliomas. I am now saying even high-grade gliomas have a defined pattern of growth. They grow along a wide fiber tract and they displace the tract. They are high-grade only by virtue of their cellularity. Like this is a high-grade glioma. They are high-grade. This is from the orbital gyri. These are high-grade gliomas. They are high-grade by virtue of their cellular mitotic activity, but they are also defined, and you can you can make a beautiful plane of dissection around it, and you can remove this tumor circumferentially. There is no need to debulk the tumor and remove this tumor. There is a possibility of complete removal. I'm not, of course, saying that you can cure a high-grade glioma or a glioblastoma, but this is the best way of removing a high-grade tumor. This is another high-grade tumor. Now, this high-grade tumor, you can come and debulk the tumor, debulk the tumor, debulk the tumor. If you debulk the tumor, then you lose the planes. Then you sometimes say, okay, no, this is normal brain, this is abnormal brain. You lose the plane of dissection. But if you have the art of going around the tumor, you can remove this tumor radically and more aggressively. Of course, we were also doing intratumoral debulking, removal, coagulation, this and that. But many of these tumors can be removed completely without a single coagulation. This is another tumor you can see in the inferior temporal gyrus. This is a very safe area. Now, if this tumor there is no way you can come and remove this tumor piecemeal. That I'm not saying and I'm not contradicting, but what I am trying to say is that these tumors are defined and well defined, and you can remove them like a meningioma, and you can remove it with minimal mapping, minimum monitoring, no awake, and all those things, which are very crucial in the understanding of these tumors. Now, where is this tumor? This tumor is in the fusiform cortex. You see how it is elevating the atrium and the temporal horn and the occipital horn. This tumor is in the fusiform, in the arcuate fascicle, and this tumor can be removed beautifully en masse. This is a safer zone, not like motor strip where you can have a conflict and you can have a danger where you need some kind of monitoring, where you sometimes need subcortical mapping, bipolar mapping, awake craniotomies and things like that. This, of course, should be, in my estimation, you must remove this tumor en masse. If you are removing this tumor piecemeal, you can leave some tumor behind, and there is a well-defined plane of dissection around these tumors. The other tumor, which is a very commonly discussed tumor, is the insular tumors. Insular tumors are also, you see, they arise from the arcuate fascicles of the insula, and they grow in a defined pattern. Insular tumors are difficult and dangerous tumors, not because they are dangerous by virtue of their tumor, but they are dangerous because there is a web of blood vessels in the sylvian fissure. You damage the brain in this area, nothing much is going to happen. But if you damage one blood vessel, you can create a big hemiplegia. So you're not allowed to damage any blood vessel in the sylvian fissure. That is the bottom line of this surgery. And of course, you have to learn the anatomy of the sylvian fissure, the sulci and gyrus of the sylvian fissure, the circular sulcus, the shape of the insula, the fiber tracts around the insula, the insular cortex, this operculum. These are like curtains. Operculum means curtain. You can open the operculum, and this beautiful pyramid-shaped structure is the insula. They are short sulcus, they are long sulci, and there is a central sulcus which is in the continuity of the central sulcus of the brain. There are wide fiber tracts. There is IFOF going from here. There is uncinate fibers going from here. This is Lyman insulae. And there are various other tracts. There is extreme capsule. There is external capsule. There is claustrum behind the gyrus of the insula. So there is no excuse. If you have to do insular surgery, insular region surgery, you have to know the anatomy of these gyri, and you have to know how. So this is a beautiful arcuate fascicle for you. This is this is around the insula, just circumferentially, arcuate. And these fibers are very critical from the arcuate fascicle of the Broca's area. They connect these fibers. These are the IFOB, this is the middle longitudinal fibers. You see, this is the IFOB, this is MLF, and this is circumferentially how to learn this anatomy. There is no way. These are the arcuate fibers of the region of the Broca's area. These are the arcuate fibers around the insula. These are the various fiber tracts that you can see in beauty in this specimen. And we have done in our department several dissections, and many of young people in the audience are invited to my department to learn this dissection. So this is in the region of the superior temporal gyrus. And you have to know that this superior temporal gyrus is a relatively safe area, but in the region of the motor strip. And you have to, if you take a biopsy, there is no point in taking a biopsy. These tumors can be removed en masse, and I will show you. And this is a post-operative specimen. This is another tumor, how these tumors involve the operculum, how these tumors go in the insula, how there is a plane of dissection from the internal capsule, from the claustrum, from the various parts of the other critical areas of the brain, and how you can make a dissection are important things to learn. Now I will show you one very important in the speech area, in the region of frontal operculum, in the region of par orbitalis and par opercularis. And this is the tumor going in the insula. This is the tumor. My concept is that it displaces the fibers. It displaces the critical Broca's fibers, and it involves, the speech is involved not by invasion or destruction, but by pressure. So this is the tumor, and this is the tumor. You see how it is displacing in the region of superior, in the region of inferior frontal gyrus on a dominant hemisphere. So you design where exactly it is located on the preoperative mapping and the preoperative functional mapping and all those things you have to do. And you have to do awake also. If you have to do, you can do awake this surgery. Now you see this tumor and how I identify the tumor from normal, from abnormal. See, either you don't do, if you are worried too much about, damaging, then you are not allowed to do. See, this is, you see, this is the brain, this is the tumor. This is the normal brain. Now you see how I make a plane of dissection in a very critical area of the brain. You see, it is in the Broca's area. And if you are, if you are having doubts about Broca's area and about tumor and about you can create speech deficit, of course you can create speech deficit. I'm not saying you cannot create, there are dangers in every neurosurgery. But these tumors are defined tumors, and your aim of surgery is to improve the speech, not to worsen the speech. You have to improve the quality of life, and you have to improve the longevity of life. You see how I'm saving the blood vessel by doing this kind of a blunt dissection. Of course, whenever necessary, you can do sharp dissection. Now you see how I'm saving the vessels. I have already told you in the region of insula, the more important and the more critical issue is saving the blood vessels. Any single blood vessel that you damage, if you damage one vessel, you have created a disaster. Here, a little bit I have edited, not much. See, now I am, and this editing has not been done by me, by my very illustrious partner. And then you see how I am developing a plane of dissection. You see this lip of tumor? And you see how I'm removing this tumor in a very critical area of the brain, in the region of the Broca's area. And if you have doubts, then you're not allowed to do this. You can make the patient speechless after surgery, and you will remain speechless for the rest of your life. You will not be able to give a lecture like this. And this is very little editing. You see how I am saving the blood vessels and how I have saved all the blood vessels, including the veins in the region and all the arteries and all the small vessels, just by having an art of dissection of the tumor from the normal brain, normal parenchyma. That differentiation from normal to abnormal, if you can identify, you can remove this tumor. And you can remove this tumor with minimal monitoring. And even awake craniotomies can be avoided if you can develop this art of dissection. Even functional, like mapping during the operation, can be completely avoided, and you can do not radical, but supra radical surgical resection. And this is the patient post-operatively. Of course, many of you will not understand the language, but he's saying that he's talking in an immediate post-operative period. Some little bit slurring is there, but you see how fresh his face is and how fresh he's little bit looks dazed, but this is very immediate post-operative period. And this tumor has been, and according to my calculation, he's cured from his tumor. This is another tumor you see in the insular region. Insular region surgery is very important. I have told you, you can do complete resection. You can remove total resection. You can do supra total resection by this art of getting a plane of dissection. By knowing very well and critically well that you cannot damage one single blood vessel. If you have to, I can give you one thing. If you have to coagulate one vessel in the Sylvian fissure, you will create hemiplegia. So these are the tumors. You have to first know whether it is in the temporal brain going into the frontal brain or frontal brain. Now this looks like frontal, but this is not frontal. This is temporal tumor going into frontal. And this, I don't use it, but intraoperative ICG monitoring can be, this is the tumor removed. And you can do ICG monitoring to identify. We had published an article on this subject, but there is actually no need to do this kind of monitoring. You have to open your eyes and see by yourself where is the artery. But you can use various kinds of monitoring. If you are very happy with wasting time in your life, you can use continuous go on monitoring and don't remove the tumor. You can continuously doing monitoring and mapping and ask him donkey, monkey, table, chair, and not remove the tumor. Or you can remove the tumor. Basically, your job is to remove the tumor, and you have to remove the tumor safely, and you have to remove the tumor aggressively. Most important in the insular surgery is to save every blood vessel. You have to know where the tumor is going and how the tumor is going. Now I will show you this tumor. This is insular tumor. You have to know that this is going in the uncinate area, in the frontal area. You see in the uncinate tract, fiber tract, and then this is going like that. This is another tumor. Actually, I'll show you this one. This is preoperative in the region of uncinate, and this is postoperative resection. This is the tumor. You see how it is going and how it is displacing the tract. And this is the tumor I'm going to show you in the region of insula and how it is going in the frontal. Just carefully look at this tumor. This is very little editing. In the insular area, it is difficult to remove en masse. If you remove en masse and you damage one vessel, now see very carefully. See, this is the tumor. So first what I am doing is little bit I am debulking the tumor, knowing very well that the tumor is quite big. And this is the tumor in the frontal area going downwards in the temporal. Okay, this is frontal opercular tumor. First I am debulking the tumor after identifying the tumor from the normal brain. Okay, once I have debulked and once I have made my arteries clear, then I will remove it en masse. You see this dissection. This is almost unedited version. This is a little bit edited. Now you see how I'm removing this tumor from the region of the frontal cortex in an en masse fashion. This plane of dissection, you know, this has to be learned. How to find out tumor from the normal, from the abnormal brain. This art of dissection. And here your monitoring will not be helpful. Your feel will be helpful. What they call haptic touch, your feel, your fingers, your computer in your fingers. And how you, when you're doing this, removing the tumor with this dissector, how you're feeling, how you're identifying normal brain from abnormal brain. See, when I'm removing the tumor from the frontal brain, I'm a little bit more generous with my tumor resection. When then I come in the insular area, you see now I'm doing in the insular area, then I'm doing it piecemeal and gently, more gently. And now I'm removing the tumor from the insular area. See, identifying normal from abnormal and identifying, you see, this is suction. I'm using the suction to break the tumor. There I was using the suction to dissect the tumor. So this suction is a very critical tool of your neurosurgical life. And you can do this tumor resection, you see, quite radically and aggressively. And this is a very radical tumor resection. You see, this was the incision. This is the postoperative tumor cavity, which is quite radically removed. Here some tumor has been left behind, but this also should not be left behind. So this is another tumor which is essentially removed en masse. This is another insular tumor. So there are many in our neurosurgical life. We can show preoperative and postoperative. Now you see this is a high-grade tumor, insular cortex. Some people describe transoperculum, this thing, but there is no, you know, you have to open the sylvian fissure and you have to then remove the tumor inside the sylvian, identify. You see, this art of opening the sylvian fissure has to be learned. If you are a vascular surgeon, you have done vascular surgery, but in glioma, the brain is little bit tight, and the brain is in a malignant tumor, the brain is more tight. So you have to open the sylvian fissure and aggressively open the sylvian fissure, and then you have to avoid damage of the sylvian fissure. You see, now I have reached inside, opening the sylvian fissure, and then I am working on the tumor. You see, this is the tumor I have identified. I have sacrificed some of the cortex. Now this is the tumor in the insula. Now you see, I remove this tumor en masse. You see, this is a high-grade tumor, and I am devising a plane around the tumor. If you do piecemeal, of course, you can remove this tumor. More important is if you have to remove this tumor completely, you have to identify the plane of dissection and then open your eyes completely, have the feel in your hand. Bottom line is, if you coagulate one vessel, you have damaged the person. You cannot coagulate. And if you damage one perforator of middle cerebral artery, you may be very, very lucky if this patient does not have a serious deficit. So if you want to do this dissection, you have to save. If you cannot do, then you do piecemeal resection. Piecemeal resection is also possible in this high-grade tumor because the plane of the color of the tumor is much different from the normal brain. You see, in high-grade gliomas, the color of the tumor is more different from normal brain. But there is a big, beautiful possibility of removing these tumors in the region of insula en masse. These tumors involve the arcuate fascicle of the insula and displace the adjoining structures. They displace the adjoining. You see, I'm actually holding the tumor with a biopsy forceps and then removing the tumor in a circumferential fashion around in the region of insula. You must remember, I'm working then because this tumor is breakable, I'm breaking the tumor and then I'm removing the tumor en masse in the region of insula using the suction as a very aggressive tool of dissection. And then you see I have identifying normal from abnormal, identifying white from yellow, identifying white from gray. You see, this is the part of the tumor which is being removed completely from the region of insula, and complete tumor resection is possible. And of course, this is a little bit high-grade tumor, but radical resection is associated with better outcomes. Now we know it clearly. Now we know it with the work of various illustrious people in our history of neurosurgery. We know how these tumors can be, this is immediate post-operative scan showing tumor resection. Pape circuit, from my department, we have studied Pape circuit very beautifully. And I can say that no anatomical dissection in the world is as beautiful as we have done in this article of mine, with, of course, not mine, article of my departmental colleagues who have done. I have just there to enjoy the fruits of their labor. And Pape circuit, we know how the cingulum is related to Pape circuit, parahippocampal gyrus, hippocampus, uncus, dentate gyrus, fornices, how the fornix come, how the fornix turn, how they go into the mammillary body, then mammillothalamic tract, the relationship of the mammillothalamic tract with the other critical areas of the brain, and the entire Pape circuit was dissected and removed like this, like never before. You see, the whole Pape circuit is shown here. The olfactory striae, the fimbriae, the hippocampus, the fimbriae, the fornices, mammillothalamic tract, thalamic tract, the thalamic connections, and the cingulum, and the connections with the temporal brain. This whole of Pape circuit has been removed like never before in the history of neurosurgery. So you have to know, if you have to do limbic system surgery, this is the cingulum. The white fibers of the cingulum go to the precuneus in the parietal lobe. This connection is so important, and the singular tumor go along. So if there is a cingulum tumor, it goes along the fiber tracts of the cingulum and displaces the adjoining projection fibers. You see, this is the tumor. It is displacing the projection fibers. This is the tumor in the inferior temporal gyrus, and it displaces in the parahippocampal gyrus, and you can come from the inferior temporal gyrus to remove this tumor. This is in the region of parahippocampal gyrus. And how, if you have to remove this parahippocampal, everybody knows, come from the inferior temporal gyrus and remove this tumor. But if you have to learn anatomically how this tumor is displacing the inferior longitudinal fasciculus, how it is displacing the superior longitudinal fasciculus, how it is displacing the arcuate fascicle, and how this inferior longitudinal fascicle, how it is displacing the optic radiations, which are also very critical. And you have to, you see, these are the optic radiations. This is the hippocampus. The anterior part of the temporal horn, these are the optic radiation. The anterior part of the temporal horn is without optic radiation. So when this Myers loop, as we know, this is the hippocampus. If you come from the inferior temporal gyrus in the anterior part of the temporal horn, there is no optic radiation, and you can do amygdala hippocampectomy by the inferior or middle temporal gyrus approach. This we described for the first time in 1994. I described with my colleagues inferior temporal approach for amygdala hippocampectomy. The other beautiful structure that is of my recent interest and of my recent paper is corpus callosum. You never will imagine how corpus callosum is interacting with the whole brain. It forms the foundation of the brain. It forms the infrastructure of the brain. How the corpus callosal fibers goes to the tapetum, forceps major, forceps minor, how they go around the various fiber tracts of the brain, how the IFOF is involved, how the various fiber tracts. This is a subject of my latest interest, and how it covers the ventricle, how it covers the temporal horn, how it covers the atrium, what is corpus callosum. This is a beauty, and I call corpus callosum as the foundation of your understanding of the brain. So we have recently written a beautiful article on this subject, and this will be published very soon. These are the tapetum, and these are the fibers of the corpus callosum, how they grow and how they grow in get involved with the entire brain. You see this beauty of dissection from my department, which we recently did. And of course, you can do fiber tract studies with radiology, which mimic. And now you see how the corpus callosum fibers are going. There's no way you can do corpus callosotomy by cutting the fibers like this. You have to open, give a transverse incision and open the fiber. If you're doing cutting like this, you can create issues. So the best way of opening the corpus callosum is to do a transverse incision, and the tumors involving the corpus callosum grow from one side to the other side. They remain within the fibers of the corpus callosum. They displace the adjoining fibers. They displace, and you can remove these tumors. Of course, it may not be correct to remove these tumors en masse. But if you have the philosophy that these tumors have a defined plane of dissection, you can do these tumors beautifully. Tumors in the splenium accordingly can be removed in a beautiful fashion by going across the midline and removing these tumors. Not easy, of course. I'm not saying anything in neurosurgery is easy. Everything is dangerous and difficult and potential have complications. But what my aim is today to give you a concept that radical tumor resection can be done in an en masse fashion, and in a fashion where you can design a plane of dissection from normal brain. We had described an approach for deep-seated tumors in the region of caudate nucleus. Orbital cortex approach. You see this, I described this approach about 20 years ago. Orbital cortical approach to lesions around the frontal horn of lateral ventricle. What are the indications and what are the parameters? We described this. And recently we described the anatomical correlates of this approach. Orbital cortical approach, we described the various anatomical. So we had two approaches. One is medial approach, or this is the orbital cortex. This is the medial entry point, and this is the lateral entry point. Two approaches to reach the deep part of the brain near the caudate nucleus, and how to save the various tracts, how to save the uncinate cortex, how to save the IFOF, how to save the Lyman insula, how to save the fibers of the anterior commissure, and how to go safely in the region of caudate nucleus has been described in our article on this subject. And you see some of the fibers, if you're coming from the orbital cortex, which will come in the vicinity, so you have to know where is the insula and how you have to save the insula and the various white fiber tracts and go into the orbital cortex. So this was my various surgical parameters to come from this orbital cortex. And this is the craniotomy, and this is the orbital cortical approach to reach the region of the caudate nucleus. So this is the caudate nucleus area. You can come interhemispheric, but then this will become very deep and this will become very dangerous from here. You can come from here, which will not be good. So this orbital cortex is a shortest route, is the safest route, and it is having connections with the various projection fibers. But know that these are defined tumors. You can develop a plane of dissection and you can remove these tumors completely. So this is another caudate nucleus tumor, and this has been removed completely. So know the beauty of the tracts, know the beauty of the tumors, know the beauty of brain. Know that these tumors can be dissected completely. Know that these tumors are disciplined tumors. Know that these tumors are aggressive tumors. We should, of course, know the molecular pathology, the WHO 2021 grading, but we are surgeons. We have to do surgery. We have to remove the tumor. Whether it is histologically grade 1 or grade 1.5 or grade 2.5, that is for the pathologist to identify. They have to do molecular studies. They have to do then surgery. But if we know our surgical planes of dissection, we can do beautiful. I don't want to, I will discuss about, Ugur today has discussed in last week about brainstem. I will study about brainstem tumors in another juha symposium, in a subsequent symposium. But I just want to show you, this is the dissection from my laboratory, and also, of course, nobody in the world can be better dissected than Dr. Nunes from Argentina. And Dr. Sukhdeep Jhawar. Both of these, of course, Nunes is the principal artist and Sukhdeep is another artist, and these people have done this dissection, and you see the beauty of brainstem dissection. I will discuss the surgery of brainstem in another webinar, but I just want to show you that even brainstem gliomas, which Ture had shown beautifully, what Ture was showing, how to remove midbrain gliomas radically. And when he's showing midbrain tumors to be removed radically, he has completely ingrained that these tumors are defined tumors. These tumors displace the fibers. These tumors can be radically removed. You have to know, there will be no, you cannot have awake craniotomy when you're doing brainstem surgery, your pons surgery or midbrain surgery. You have to have eyes. You have to have hands. You have to know the plane of dissection, and you have to have the concept that these tumors are defined tumors. They are not invasive tumors, and you can develop a plane of dissection from normal, from abnormal. So fiber tracts is our understanding and our new understanding, and this is what I have to give this message. Thank you very much. Juha.
Okay, Juha?
Thank you very much. Can you hear me?
Yes, yes.
Okay, thank you very much for the fascinating lecture. So I think there is a lot of anatomy, and this lecture is very important. So we have to learn anatomy, more anatomy. I cannot teach anatomy, so I was very fascinated with this concept and strategy. I noted that I have done it many times, but without so much knowledge of anatomy. So we have to learn more anatomy and the fiber tract dissection, and nowadays also imaging gives good basics to remove these tumors radically, like Professor Goel showed. So we can discuss now. Okay.
Professor Goel, thank you for your amazing lecture. I think this is really amazing.
Thank you, Ben. Thank you.
I watched your operation, like when you remove the acoustic neuroma, you also use your dissecting and the suction very well, and without any coagulation. That's really amazing. I think, Professor Hernesnemi and myself, we all love the quick and the clean surgery. And you are one of the champions.
I will also say one thing. This dissection of gliomas is, of course, different from blood vessel dissection, different from subarachnoid dissection. In subarachnoid dissection, you have to move your instruments in a different fashion. You have to use micro scissor. You have to use a more elaborate microbipolar. That subarachnoid dissection is different. Glial dissection is different. Do you agree?
Yeah, I totally agree with you that your finger, the feedback from to your fingertip is the feeling of your fingertip is the most important thing to recognize.
See, my message to the young people is, we should know the anatomy and we should have the experience. We should more and more, as Juha always says, that you have to be in the operation theater. You cannot be outside the operation theater and, we are surgeons and our life has to be revolving in the operation theater. More we operate throughout the life. Juha says 1,500 hours in the operation theater. 1,000, so many hours in the operation theaters are very critical. And more you are working with the brain, more you are working with the blood vessels, more you are doing anastomosis. You cannot become master and king, and you cannot become bin in one day and say, I do dissection. You have spent hours in the lab doing dissection on rat aorta, on rat carotid artery, on rabbit carotid artery. You have done dissection. You have learned the art of suturing on the glove. You have done in the lab. You have spent hours and hours. You have not become Binzu by just giving lectures, or you have spent your life in the operation theater. That is the message Juha gives always, that you have to, if you want to become big, if you want to become, if you want to do this art of dissection and surgery, you have to spend time in surgery, and you have to love surgery. You have to enjoy surgery, and you have to see that your dissection is patient oriented. If you do dissection like this and you create hemiplegia, do you think I will be happy and say like this, do like this, do like this? You cannot create, you are working on human bodies and human brain. You have to be 100%. Of course, in neurosurgery, we have complications. You can create deficit after surgery. But if you create deficit after deficit, then you have to change your line. So if you're doing bypass on moya and you create hemiplegia, will you accept it? Maybe it happens. But if it happens all the time, then you will stop. What do you say, Juha, about this?
Yeah, it is, of course. I think our office should be in operation room. There we learn in the operation room, and if you are not faced with the complications of surgery, so you will not learn. So of course you should minimize the complications and analyze them very carefully. Then you learn. You should learn from the complications always, and also publish the complications. And this is extremely important, to share the knowledge around the world and to other colleagues. So we, as a group of neurosurgeons, we will get better all the time when we share the complications. You should not hide them or tell that I have, in my series, there are no complications. This is nonsense. If you do a lot of surgery, you will have complications, but you should analyze them. And like Dr. Drakes always said, that if we get a second chance to help those who were heavily invalidized or died, this we cannot have, but we can analyze our complications, and in this way to protect the future patients and future cases. This is extremely important.
I know, this is a complex subject. Low-grade glioma is an emerging field. Low-grade gliomas and high-grade gliomas, still people are learning and trying to learn more and more. Still, people are evaluating whether monitoring is how much helpful, mapping is how much helpful, functional brain recording is so much helpful, intraoperative MRI is helpful or not, RLI is helpful or not. People are still trying to evaluate and learn. So there are many questions that may arise. So I will be happy if the young people in the audience can ask questions, and if possible, I can answer, or Juha can answer, or Binzu is sitting, Takeshi can answer. If there are some questions from young people, it will be.
Can I ask a question, Dr. Bennett?
Yes, yes, please go ahead.
Yes, go ahead, please.
Yeah, I'm Dr. Saravanan. I have been teaching anatomy and physiology for about 15 years in USA. I never had a love for surgery. I thought that's a man's world because I was much more interested in pediatrics and genetics. But I like to suture and stitching. You were talking about gliomas in the Broca's area. of speech. What is the incidence of tumors in the vernix area? Is it also common?
Yeah,
And
yeah.
is it removed easily? Or how much does it affect speech if it has happened in the past?
Purnima, one thing you must know, you are not, nothing is easy in the brain surgery.
Yeah,
Nothing is easy in neurosurgery. That is
exactly.
what.
I'm really right now really
Yeah,
scared
yeah.
even talking to you.
No,
Really,
no,
doctor.
no, just listen.
Okay.
So one thing is for sure that nothing is easy in neurosurgery.
Okay.
That is one. And second thing is nothing is without a potential danger. You can create a complication, like you were saying about Wernicke's area.
Yeah.
You were saying about Broca's area.
Yeah.
You can have a very serious complication following surgery in these areas. On the other hand, you see if there is a tumor in the Wernicke's area and there is some kind of speech involvement already there. So you can actually, your surgery is to improve the person. Your surgery is done so that the symptoms are improved or they are better. That is one thing. Second thing is you are removing the tumor to improve the quality of life. That is number two purpose of surgery. Number third purpose of surgery is that if you are able to remove the tumor radically and quite completely, the malignant potential of the tumor. Some people are saying that if you are doing radical resection of low-grade gliomas, the possibility of them turning into malignancy becomes much less. And
Okay.
these are low-grade kind of tumors, many of these tumors. You can actually get a cure out of this surgery. So many things when you are operating is different from when you are learning anatomy. And there are various issues that the surgeon is confronted, and he has to be absolutely philosophical, absolutely rational, absolutely technical, and he has to use all the modern gadgets that are available to him and do that surgery.
Okay. And yeah, one last question. What do you think is the success rate when you consider removal of meningiomas, gliomas, and other kind of benign tumors which are space occupying? Roughly a percentage in India or under your tenure that you have done surgery?
Purnima, that
Roughly.
is a question. This is unfortunately, you are not in neurosurgery, and this question is quite
No, the reason I asked is because
Yeah, excuse me. We have a comment from the panel, Dr. Goel. Can we use finger dissection instead of sucker for the section of the plane?
No, actually, finger, that is, I will say that is one of the very interesting question, and I will say, if you have the concept, and what we do is normally we are using the suction like a finger, like Ugo Ture was saying last time. He's holding the bipolar, and that bipolar is like his fingers. And we are using the suction, or we are using bipolar, or we are using bayonet like a finger. It is an extended finger. Because your finger will not go exactly inside the brain, and that will look very, I will say don't do that. Don't do that in modern neurosurgery. It may not be correct, and it is not correct.
Okay, any more questions from the panel?
Professor Kaur?
Go ahead.
So, can you tell the indication for the radiotherapy or
radiation
chemotherapy?
Yes. Now, this is a very important question, Ben, you are asking me. Now, there are, when you see radiologically, you can say low grade. But nowadays, it is a day of molecular biology, day of advanced histological examination, whether it is, and now there is 2021 WHO classification. And as I mentioned to you in my lecture that my wife is a neuropathologist, I take her opinion regarding the nature of the tumor. That is one. Second thing is we have advanced radiation oncologist who will decide when is radiation necessary or not. Advanced medical oncologist who will decide whether indication of chemotherapy or not. Normally, I don't interfere in that decision. But what I can tell you is that if you have done low-grade dissection, low-grade tumor, low-grade, a radical resection, many of these tumors you can avoid radiation treatment completely. And radiation is given in a very small number of my low-grade tumor surgery, because radical tumor is a very good possibility when you remove the tumor en masse. You remove the tumor supratotally. So that tumor, of course, you will give when the tumor is high grade by molecular parameters and other parameters. Then that is the answer.
Okay, so if there's some small part of the gyrus, it looks normal, and a very thin slice, you can find the circles of the gyrus. So would you remove this kind of looks normal gyrus?
Yes, this is another question. You see, when I was removing the tumor bin, you have realized when I was removing the tumor, I was removing the entire gyrus. Now I am saying that these tumors arise from a white fiber. White fiber is not cortical gyrus, cortical fiber, cortical bundle. Now what I have seen is here, it arises from the white fibers, and the cortical gyrus is completely part of the tumor. The whole thing, the arcuate fibers and the entire, I removed the whole gyrus along with the tumor. And then we studied all parts, multiple parts of the tumor, including the gyrus, including the subcortical part, including the various parts of the tumor, and did histological examination. I have recently written a paper which is going to be published, and you must read that paper, that the entire thing which I have removed is all tumor. Only the periphery of the tumor, where it is infiltrating into the brain, or some normal brain I have taken, except for that part, the entire thing is a tumor. So this is another beauty, and I am studying this, the gyral pattern, where how much means you can, whether it has to be subpile dissection and those kind of things are discussed. But what I am telling you is the entire, include the gyrus in your dissection, and you remove the whole thing, and mass is the best way of removing this tumor.
Okay.
Okay, more comments or questions from the panel?
Can I ask one last question, Dr. Bennett?
Yeah, hold on, ma'am. We have another question from someone here. Hold on. Oh, I had that. Oh yeah. I'm sorry, I got that question already. I'm sorry. I lost that question.
Can I
okay, yeah, go ahead, sir. Go ahead, sir.
So yeah, Professor, it was a great talk. It's Likith Alakani from Glasgow. So I was asking, what are your views on doing awake speech monitoring when you're doing Broca's areas lesion or insular lesions? The insular tumor you showed us, we would typically do awake with monitoring. So what are your views, sir?
This is a very important question. You see, I'm not trying to say that awake, you see, one thing is, please don't misunderstand me. I'm not trying to say that neuromonitoring is not essential. I'm not trying to say awake craniotomy is not essential. I'm not saying intraoperative neuromonitoring is not essential. Those are important. But but what I'm trying to say is these can be avoidable, and these can be avoided if you design a plane of dissection, because neurological deficit, like if the person has come to you with hemiparesis, if you design a plane of dissection, the hemiparesis should improve after surgery. Hemiparesis, or the projection fiber involvement, is not by virtue of destruction or invasion. It is by virtue of pressure and by virtue of deformation. That is my concept. My concept is these tumors arise from a white fiber tract and displace the adjoining white fiber tracts and even the projection fibers. And there is a possibility of designing a plane of dissection. And in the Broca's area, of course, it is a speech area and a critical area, the speech fibers and the speech cortex is displaced by the tumor. And if there is a preoperative speech disturbance, if you are removing this tumor as a nodule and avoiding the speech area, the speech should improve after surgery. Awake craniotomy and awake surgery is important, of course, in speech area surgery. There is no question, and you must do it. But there is a possibility of having an en masse resection even in Broca's area, which I showed you on multiple occasions during this presentation.
Okay, very good. Okay, Juha?
My last question, can I go
No,
ahead?
no, hold on, ma'am. Hold on, ma'am. Juha? Juha, are you there?
Yeah, I'm there.
No, wait for Juha.
Okay, sorry. I'm sorry. You let me know, Dr.
Excuse me, Juha, are you there?
That was in chat a question about the rate of recurrence. I think in the low-grade gliomas, it is very close to 0. But of course, in the high grade, you will see nearly always recurrences. These are exceptions in the glioblastomas or even grade 3. How is your experience, Atul?
See, my concept is very clear that once you get a tumor, there is a possibility of getting a recurrence always. You cannot say that I removed the tumor and I have cured the tumor. Once a tumor, always a tumor. Once an acoustic tumor, there is a possibility of recurrence of acoustic tumor always. Once a pituitary tumor, there is a possibility of recurrence always. Once a high-grade tumor, there is a possibility of early recurrence. If there is a high-grade tumor, the rate of recurrence is quicker or the recurrence becomes early. In a low-grade tumor, the recurrence is possible, but the recurrence can come after 5 years or 10 years or 20 years. In a low-grade glioma, if you do not operate, the chances of turning that low-grade into a malignant transformation is much higher. This is what people say. This is what Mitch Berger says. This is what Dufault agrees. The chances of, if you remove the tumor radically and completely, the chances of malignant transformation are much less. If you remove the tumor radically, the symptomatic, if there are symptoms like convulsions, like various functional deficits, the chances of improvement of those symptoms is quite good. So your surgery improves the symptoms, improves the quality of life, improves the longevity of life, and decreases the chances of malignant transformation and decreases the chances of recurrence. There are several cases now in my series where there is no recurrence, no growth of tumor. But I am not saying that they are cured and they will never recur. So we are keeping finger crossed. Our follow-up is not very big, like 20 years or 30 years for these low-grade gliomas. So we will see. But I am not saying they will never recur or this thing. Recurrence will be more in higher grade tumors. But even in higher grade tumors, you can develop a beautiful plane of dissection and you can remove it radically and supra-radically. And more radical the tumor, less the tumor burden with the patient, less the chances of recurrence. So this is my concept.
Okay, thank you, Dr. Goel. Dennis has a question. Go ahead, Dennis.
Hello. I had the question actually to both of the professors, Professor Atul and Professor Hernesniemi. Just a small tip for the residents: when you remove a glioma or a metastasis and block and you are dissecting circumferentially, let's say you use the bipolar, you create the dissection plane with the suction, and you try with the bipolar to pull the tumor to the center as a technique. And the second question is, when you're creating this dissection plane with the suction, we are told to keep the suction as close to the tumor, as close as possible to the tumor, not to create any damage in the healthy tissue. Is there any tricks in this technique?
So Juha, I will first answer, and then Juha can give, and Bin can give. See, the thing is, if you have heard Dr. Toure's lecture last time, he was talking about midbrain gliomas. And I asked him questions about why he's holding bipolar in his hand, right hand. He said that this bipolar, he's not using coagulation, but those are his fingers. He's using them as his fingers. Similarly, suction, you can use it as a dissector. You can use as a finger, and it can give you a touch feel. It can give you a feel. Where is the tumor and where is the dissection? Where is the normal brain? And you can use suction to design and dissect into that plane. You don't pull anything out. If you pull, you can damage the normal structure. To develop this plane of dissection is an art which has to be learned with period of your study. Juha.
I'm doing the same way, but I'm having the sucker in the left hand, and I'm using also bipolar forceps to dissect around the tumor. I think when you say that you never use bipolar, then the question comes, how are you doing the final hemostasis?
Yeah, so that is another important question. Now, when I was showing the tumor dissection, I realized, you see, when we do glioma surgery, we coagulate, and I'll keep on achieving hemostasis and coagulate. And we continuously coagulate, like we know how to. Now, the thing is, which I realized, that you come around the tumor and you have removed the whole tumor and you have not coagulated even once. And of course, when you come out, you have to achieve hemostasis, you have to coagulate. Whatever is bleeding here and there, little bit here and there, some vein, some artery. So of course you have to coagulate. But the whole tumor you have removed and you have not coagulated even once. So that experience I have got now, and even Bin was there, Bin was talking about it, like you do acoustic tumor. Many people do acoustic tumor by continuously coagulating, cutting. So what I have realized is you do the tumor debulking, there is no need for coagulation. Coagulation inside the tumor is waste of time, and coagulating outside the tumor is a technical mistake for acoustic tumor. Similarly, I have realized if you are doing insular glioma, coagulating inside the insular glioma is a waste of time, and coagulating outside the insular glioma in the region of insula is a disaster. So you have to coagulate very selectively. You don't have to, there are some people who use coagulation much more than others. That is all right. But my learning process has been that coagulation is a very important tool. Bipolar has revolutionized neurosurgery. Bipolar tool has to be used with precaution and selectively, and don't use it too much and don't overuse it. That is the way I do it. Juha.
Yeah, my question was actually that after removal of the tumor,
then
you have removal, then you have to check the hemostasis. How are you doing? With bipolar and compression and rating? And...
Bipolar. With bipolar, of course.
Okay, Verdab has a question. Go ahead, Verdab.
Thank you, Dr. John. Hello, Professor Atul. Hello, Professor Juha. Thank you very much for this presentation, as usual. So, Professor Atul, my questions again regarding that coagulation issues. Is it exactly the terminal trauma that you are afraid of while doing dissection of the tumor that ban you from using the bipolar during dissection, or it is something technical? And the second question, what exactly you think the most to help us distinguishing between the normal brain and the tumor? Is it the texture, the consistency, or the color of the parenchyma that will distinguish?
That is a very beautiful question.
Thank you.
From a beautiful neurosurgeon.
Thank you.
The thing is, you have to know about the consistency of the tumor, the vascularity of the tumor, and the color of the tumor. Those are different from normal brain. And that you have to know what is what. If you are confused during operation, then you stop. If you are confused between normal brain and tumor, then you just cannot go ahead. You have to stop. If you are able to have continuously during the operation that plane of dissection, the consistency, vascularity, you can hold the tumor in one hand, hold it and pull it and dissect with the other hand, you are allowed to do. If you are having doubt, no, I am having doubt. No, I don't know this is normal brain or tumor, you stop. You cannot go further. You should not go further. That is one, because those you are dealing with the very critical area of the brain. You are dealing with motor area, speech area, visual cortex, angular cortex, arcuate fascicle. If you are having doubt, you cannot go further. But my feeling is you can develop in 100% of cases a plane of dissection between normal and abnormal if you are experienced enough in this field. That is one. As regard bipolar, you see, I am not saying bipolar you don't use or not use or don't use. I am saying you use it when it is required. You use it when it is required, because if there is a spurter going on and you say I will not use bipolar because Dr. Goel was saying do not use bipolar, that is not correct. If there is a bleeding, you have to coagulate and get hemostasis. But if you can avoid that and you can continue your dissection, you can retain the plane of dissection better, and you, in one flow of your dissection, you can remove the whole tumor without diverting your attention here and there. I think one has to learn when to coagulate, when not to coagulate. And I have, I was talking in my previous lecture that in most of my neurosurgery I have done in vascular surgery, bleeding territory, AVM surgery, cavernous sinus surgery, petroclival surgery. Much of my neurosurgical life has gone into bleeding, control of bleeding. That has been my life. And with that experience of mine, I have now come to little bit. Nobody can win over bleeding. Nobody can say, I have learned bleeding, I know how to handle bleeding. Nobody can say. But we can improve. Now I have got an inkling which bleeding will stop, which bleeding can be avoided, which bleeding can be controlled by just avoiding and pressure a little bit, which bleeding can be controlled by a little bit of a Surgicel, which bleeding can be controlled by, if there is a bleeding in cavernous sinus, you have to pack that area with Surgicel. If it is bleeding from tentorial venous sinus, there is no other way to stop the bleeding other than packing it with Surgicel. If it is bleeding from bone, there is no other way to stop bleeding other than bone wax. So there are ways to stop the bleeding, and every bleeding has to be stopped in a defined manner. Every bleeding cannot be controlled by bipolar on. If you go on and on in your surgery with bleeding bipolar, my feeling is to complete the operation will become impossible. That is my feeling. Bin, what is your impression? Bin, I would like to hear your comment on that. This question of...
Yes, I agree with you. Actually, I have, when I still resect the gliomas, I use a similar technique as yours.
Okay.
But now I only do the vascular disease.
Okay.
Good evening,
Oh, go ahead. Hello. How you doing?
I'm good, sir. I'm good, sir. How are you?
Good. Could you please
Hello.
introduce yourself? It's good to see you.
My name is Sunil and I'm from China in the Suzhou Medical University, resident in the PhD second year right now. So, like, as there was a question regarding this, like differentiate between the tumor and the non-tumor tissues. In these cases, like I want to ask, how do you differentiate the tumor, the edematous region, and the normal tissues? Mainly like the tumor we can see and we can understand, but in the edematous zone and the normal tissues, like how do you differentiate intraoperatively?
That is the art. That is the question. That is the question. That is what I am giving you a concept. That is my concept which I am giving. That these tumors are defined tumors. These tumors are localized tumors. They displace their joining structures, and there is a possibility of getting a plane of dissection. That is the concept which I am giving. And there is a possibility of making a plane even in the region of motor strip, even in the region of speech area, even in the region of visual cortex, even in the region of all fiber tracts. You can design a plane of dissection. That is the thing which I have said. That is the aim of my presentation. And if you are able to design that plane of dissection, you can limit the use of neuromonitoring. You can limit the use of intraoperative navigation. You can limit the use of intraoperative fluorescence dye. You can limit the questioning with the patient all the time. I have seen people continuously asking questions. I'm not trying to say they are wrong. Please don't misunderstand me. They are correct, and they are also, showing. Like you continuously ask, is this tiger, is this table, is this chair, is this clock, what time is this? Continuously. It is a good safety zone. But what I'm saying is you can avoid if you can define a plane of dissection. And what I'm saying is gliomas, there is a definable plane of dissection from normal and abnormal.
So then how about the vascularity? Like, is this edematous zone is more vascular in comparison to the normal tissues?
See, edematous brain, you can see with the color. Edematous color of the brain. You can see with the consistency, as this question was just now asked to me. By the consistency, by the color, by the texture, by the vascularity, you can distinguish normal from abnormal, edematous from tumor, and there is a possibility in 100% of cases, you can lose the plane. If you lose the plane, stop the dissection. If you lose the plane, you're not allowed to go further because you can damage the person. Okay?
Thank you, sir.
So it is the touching around the tumor is the most important, and then the color also to define the limits of the tumor. 40 years ago, I was by Professor Yasakil, so he told these things, but he told also that he can smell the tumor. So it was, of course, joking, but it tells that how delicate we should handle with the tumor and go around the tumor and take it out and block.
So you should smell the tumor.
Yeah,
you
Professor Yasakil was saying that he can smell the tumor. So.
Okay, any more questions?
This is a different, style. I'm just recently, I'm doing it for some years. So this is a new style of glioma dissection, new concept I am introducing. I am not saying that other concepts are wrong, but this is a concept that you should try to develop and try to see if it suits your interest. So that is the thing.
Yeah, it is a good concept. Yeah, just continue. So
thank you.
Thank you. Wonderful lecture, and many thoughts have been awaked. So I think this was very good sharing of the knowledge and strategy. So is
You
there
want
some?
to you want to finish up, Juha? Or you want to keep going?
I think we have been 2 hours here now, so
okay.
maybe this
Professor
the
Koa,
limit,
so
yeah.
tonight there were
sure.
1,300 audience for your
Excellent.
webinar.
Excellent. And
Okay, great.
and like
And
to
during
thank
the
you.
weekend, the same number are looking at the webinar.
I think we had as many. How about Takashi? Are you there?
Yeah, I'm around here. So I'm around me. Someone around me. It's a Friday night, so but around me. So I using the translating. So I'm using Japanese type of SNS and tried. The number are not certain, but not like Chinese. So not so many page members. But I want to disperse as possible in Japan. So in the future, also I like to great. And Dr. Gore is a great talk because I'm specializing in gliomas. So I use 5-ALA for during surgery, but your technique is very amazing. So unblock removal of malignant glioma. So I learn as much from your lecture, and I try to do surgery in the future. Thank you for a great talk.
Both translators are learning neurosurgery, more neurosurgery.
Both
That's
translating and learning. Yes, it's a good opportunity for me.
That's great. Okay, Juha, is there a topic
Okay.
for next? Is there a topic for next week? Or?
We wait for Atul for the message for the next Friday. So
I will give you
thank
soon.
you all for wonderful. Atul especially and the translators and John for taking care of this webinar, and see you next Friday at the same time, 8 o'clock China time.
Very good.
Morning in Miami and so on. So
Okay.
thank you very much.
Great, great session. Thanks a lot, everybody.
Thank you. Bye bye.
Very good, very good.
Bye-bye.
Thank you.
Bye-bye,
Thank you.
John.
That's why they call him the king.
John. Okay, John. Enjoy the Miami.
Okay, thank you.